Hello, this is a webinar devoted to COVID-19 and diagnostic testing, nurses on the front line. This is the first in a series of 3 webinars. This webinar today will cover an overview of testing for SARS-CoV-2 and related antibodies. I am Dr. Ann Scott Blouin. I am President for Patient Safety Quality PSQ Advisory, and I'm delighted today to be joined by Dr. Mary Rodgers, the Principal Scientist for Research and Development, Infectious Disease Research at Abbott. Disclaimer and support for these webinars, PSQ Advisory gratefully acknowledges the financial support of Abbott to provide nurses with education much needed around COVID-19. The information provided is current as of June 18th, 2020. It is acknowledged that additional information and knowledge around COVID-19 is developing almost daily and may change the guidance about the disease, prevention, detection, and treatment. So as mentioned, today's presenters will be Dr. Mary Rodgers, Principal Scientist for Research and Development for Infectious Disease Research at Abbott, and myself, Dr. Ann Scott Blouin, President of PSQ Advisory Limited. I'd like to now turn the discussion over briefly to Dr. Mary Rodgers.
Thank you, Dr. Blouin, for that kind introduction. I'd like to start out by just thanking all of the nurses who are viewing this now. It's a real honor for me to be able to present this work to you and help you understand the epidemic and testing a little bit better. My own mom is a nurse. She's retired, and my whole life I've had a strong appreciation for how hard nurses really work. And especially now during this pandemic, you're all on the front lines, and I'm so grateful to you and looking forward to being able to share this information to help you in any way that I can. So thank you for all of your work. It's really, everything you do is really important. So today we'll be covering a lot of topics. I'll be able to tell you kind of a general overview from the beginning about SARS-CoV-2, which is the virus that causes COVID-19 illness. And then we'll talk about the different diagnostic tests that are out there for detecting the virus itself. We'll talk about how the role of specimen collection is really critical to getting good test results and managing patients. And then we'll move into discussing another type of test for COVID-19, which are the antibody tests, and how that is playing into how we understand herd immunity. And then we'll finish up with what nurses need to know. So let's start out by talking a little bit about the risk factors that we know about today at this point in the pandemic that could put people at a higher risk for more severe disease outcomes. So the most common factors that we know about so far are listed here, things like advanced age, hypertension, diabetes, other comorbidities that could put someone at a much higher risk for developing serious illness. So these are important to understand as we are trying to care for patients appropriately, and especially our patients that are most vulnerable, which would have these conditions. It's also important to note that our patients who have a minority status are also seeing higher rates of more severe disease outcomes from COVID-19, and especially if they have one or more of these other risk factors. So that could be for a variety of reasons, including social determinants like access to healthcare. So we want to make sure that we're taking care of these vulnerable populations because we know that they are having more severe disease outcomes from COVID-19 infection. So I'm a virologist and I love talking about viruses, and I'd like to make sure that we all have a solid foundation in our understanding of what SARS-CoV-2 really is. SARS-CoV-2 is a virus that is an RNA virus. So that means that the genome of the virus, which encodes everything that it needs to make more of itself, is RNA, which is a nucleic acid that is also found in our bodies. We make RNA too, but the sequence of the RNA in the virus is different from the sequence of the RNA in our own bodies, and we can tell the difference, which I'll talk a little bit when we talk about tests. But this RNA is protected so that it can gain access to a cell when it infects it. And it's all these other outer proteins that you can see in this picture, whether it's the spike protein, the envelope protein, or the glycoprotein or nucleocapsid protein, these are all protecting that virus RNA so that it can get into a new cell and wreak havoc and make more of itself. And it's actually these outer proteins on the virus particle itself that our immune response is going to respond to. And the main reason is because those are the ones that are most visible to our immune system because they're on the outside of the virus itself. And so those are going to be important when we're looking at antibody responses in people who are infected, because the antibodies themselves are going to respond to that part of the virus. The virus is protected, as I mentioned, and we can see how that plays out on different kinds of surfaces when we see, and in an actual experiment where a virus is placed on a number of surfaces which are shown here: copper, cardboard, stainless steel, or plastic. And we can see that the virus remains intact and infectious for different periods of times, depending on which surface it's on. And this is important to understand, you know, from the virology part of it. The reason is because that protection lasts longer on different surfaces with all those proteins protecting the virus. But it also is important when we understand how we need to be cleaning different surfaces, because some are going to be more stable for the virus than others. So when we look at copper, in this actual experiment where they started with the same amount of virus in each surface, you can see that after less than 24 hours, the virus is completely non-infectious anymore. Whereas with cardboard, we're seeing a little bit of virus still remaining at about 22 to 24 hours. And so the virus just becomes less stable at that time point, and we have less infectivity from virus that would be on those surfaces. This is different though with stainless steel and plastic surfaces, where the virus remains infectious for longer periods of time from those specific surfaces. And so that's especially important for cleaning, where those surfaces need to be cleaned more carefully because the virus is stable for longer periods of time. Some research has also come out to show that we know a little bit more now about how long the incubation period is for someone who's been exposed to SARS-CoV-2, which is the virus that causes a COVID-19 illness. And so people who are exposed at the same time we've actually been able to do some population analysis and find that the average person starts to show symptoms after about 5 days after they're initially infected. Although we still have some people who aren't showing symptoms until as late as day 14, they're a smaller proportion, but some people do take that long to have symptoms. And so that's generally why we have those guidelines about 2 weeks for quarantine, because we want to make sure we get through that whole 2 weeks to make sure no one's going to start having symptoms. And there's actual data behind this, which you can see here. It's important to understand, though, that we also have people who never have symptoms at all. And in different groups, we have a different proportion. Some studies will say 20%, some studies will say more than 50%. And it's all kind of, you know, small studies at a time. When we look at larger population studies, we'll have a better number further on as we have more time to do those large scale studies. But right now, it's safe to say that for the people who are going to have symptoms, we'll see those symptoms develop within 2 weeks period. Another tool that we have in this pandemic are diagnostic tests, and they each detect something different and answer a different question that we have about a patient and where they are in their progression through illness and recovery with COVID-19. We have a nice chart here that shows all of the different markers that you would find in an infected person at different periods of time during the course of recovery. So early on, the incubation period, which I just spoke a little bit about, where someone is just starting to develop symptoms and may not actually have symptoms yet, that's the very early part that we call the incubation period. The only marker that we would be able to detect with a diagnostic test would be the RNA of the virus. And those are detected by molecular tests. And as time goes on and your body starts to fight against that infection, the amount of viral RNA that we can detect with a diagnostic test starts to go down. And as less of it is present, we start to see an increase in the immune response markers for recovery. The first antibody that develops in that late acute phase of an infection, which is our first detection that someone is starting to recover, is the IgM antibody. And that is an antibody that is on the front lines, comes up first, but then is also going to disappear sooner. So it lasts for about 2 to 8 weeks in most people. And it's then followed by a much longer lasting marker, which is IgG antibodies. And so those will be present, they'll start to become detectable early on, but then they'll also remain present in your body long-term, even years. When someone's been vaccinated for, say, hepatitis B, we've been able to find that people have IgG antibodies against hepatitis B decades later. And each virus is different, and each vaccine is different, and each antibody response is different. But the trend that we've seen with other viruses leads us to think that IgG antibodies to COVID-19 should also be long-lasting, but we'll be doing research to confirm that. So there's also another marker in here, which is the green section here, which is called the antigen. And that's a really important marker as well. You can see that it coincides with the viral RNA, and that's because it's the virus particle itself. So when I showed that picture of the virus particle with the RNA in the middle, the protein on the outside is called the antigen. And it's in relation to the antibody, because the antigen is the part of the protein on the virus that antibodies will detect. And so that is something that comes up a little bit later than the viral RNA, because it's just in lower abundance in general than the RNA itself. And so that marker is also going to be present in the late end of that incubation period and most abundant in the early acute phase when someone is having symptoms and could potentially be positive for the viral antigen. And so there's diagnostic tests for antigen as well. As I showed in the previous slide, the first way that we can detect an infection with SARS-CoV-2 for patients who develop COVID-19 are molecular diagnostic tests. And there's a few different names for those tests. They're called RNA tests, PCR tests, and RT-PCR tests. But they all mean the same thing. They're a test that is going to detect the viral RNA in someone's sample. And so outlined here is the way that those tests work. They work by first taking the swab from someone's airways that can then be put on a test machine where we're going to then take away everything else and just leave the viral RNA itself so that we can then make more copies of it to a point that we can reliably detect any amount that would be amplifiable. So I use the term amplify, and that just means making more copies. So there's enzymes in this kit that will make more copies of the virus RNA so that we can then come in with a detector that will tell us whether it's there or not. So that amplification process is important because it allows us to take a sample that might have just a very small amount of virus and be able to conclusively say that yes, the virus is there. That requires that amplification process. For these kinds of tests, the specimen collection is really key to patient management. The accurate specimen collection and transfer is critical so that we know that if someone does even have a small amount of virus, that virus is getting collected so that we can now enable a very robust testing process to be successful. And so that accurate test result will now enable us to have a clearer picture for a physician to be able to make an appropriate diagnosis and provide effective treatment for that patient. So you can see how the endpoint where we have effective treatment is really influenced by those first steps of accurate specimen collection and transfer to enable the test to work properly. And so that's where you can play a really key role in patient management. So all diagnostic tests have measurements that tell us how well they work. And so the first one is sensitivity, and the second one is specificity. You may have seen these measurements explained for specific tests that are out there on the market right now. So sensitivity is a measurement of our ability to detect a true positive as a positive result. So if a test is more sensitive, that means it's 99%, 90% sensitive. That means that when something is a true positive, we're able to detect it as positive. Whereas if a sample is negative, it's going to be not detected as a false positive. That can be a little bit confusing. And so we have this chart below where you can see if we have a set of test results that we know for sure are from people who are negative, because let's say these samples are collected before the COVID outbreak, so we know for sure they should be negative. And then we have a set of samples that we know for sure are positive. Those are truth. We've confirmed with multiple tests, and we know these people have the virus. So if we now set a cutoff where we draw the line between what our test calls positive and what our test calls negative, we can adjust that line so that it cuts off anything in the negative category to make us have fewer false positive results. And so the sensitivity means that line is drawn so that all of the positive numbers are counted as positive. And that's how we draw the line to have good sensitivity. Specificity, on the other hand, is our ability to call a negative as a negative. So that means a true negative sample will have a negative result in the test. And so we really want specificity to be high as well. But that's a difficult balance if our test is making it so that all of these dots are close together. A good test will separate these dots, so it's really easy to draw that line where the positives are clearly positives and the negatives are clearly negatives. And our measurements of specificity and sensitivity are always going to be relative to our ability to separate those two populations.
Dr. Rodgers, could you speak to the issue? It seems like the evolution of testing for COVID-19, it's obviously a new series of diagnostic tests. Could you talk a little bit about, based upon our history, for example, with HIV testing, how we might expect as things evolve and we learn more that testing for COVID-19 would also change?
Great question, Dr. Blouin. There's so many ways that we can look at the HIV tests and learn from them and to kind of appreciate where we are with the SARS-CoV-2 tests. So if you think back to, the 80s, early 80s, when we didn't know a lot about HIV, we were really desperate then, as we are now, for tests that could tell us who's infected and should be cared for and potentially quarantined. So back then, we also had an urgent need for tests, and we developed tests very quickly. In fact, Abbott had the first HIV test in 1985 that was approved by the FDA. And fast forward to 2019, we're still making new versions of tests for HIV as we learn more about the virus. The test that we made in 1985 is not the test that we use now. And so I would expect tests to continue to evolve. And that's really just a reflection of how the pandemic has changed, first of all, but then also how we've learned about the virus. We now know that there's a lot of different strains for HIV, and we need to be able to make sure our tests are able to detect all those different strains. Right now, all the strains that have been sequenced for SARS-CoV-2 tell us that the virus has not changed very much, but we're monitoring it because we know for other viruses like HIV that we need to be on top of that and be checking for variants that could potentially have an impact on diagnostic tests. And so as science evolves, the tests will continue to evolve to keep pace with the virus and COVID-19 as an illness.
That's really helpful. While you're speaking about evolution, could you also talk just a moment or two about how scientists in research and development here in the United States, but maybe even across the world, are trying to collaborate? And is that different from what you've seen with other diseases like MERS and H1N1 and SARS-CoV-1? Is there some differences in the way we're going about looking at this, addressing this pandemic?
That's a great question too, because I think it's kind of behind the scenes right now, and a lot of people may not realize that, we learned a lot from the first SARS epidemic back in 2003. And that was kind of a pivotal turning point where I think scientists realized that if we can collaborate more and be able to bring minds together from around the world, then that puts less pressure on the local team so that we can work together to solve a problem that ultimately becomes global. All of these outbreaks that we're seeing, SARS back in 2003, the MERS outbreak that did end up spreading further as well, and continues to potentially pop up here and there, that we need to work on this as a group effort. And it's amazing to see how now with this COVID-19 outbreak that we have that collaboration. We have people working together from all around the world because we're all in this together, and we all bring a little bit different expertise and perspective that is ultimately going to allow us to solve these problems faster and better. So,
well, and as you know and see, even here in the United States, people are at different, or geographical regions are at different points of the peak of the virus, and the question of whether there's a first phase of the virus or a first time and then a second round of the pandemic remains unknown. But certainly the global collaboration should help us, since some countries seem to be a bit ahead of us in moving down in terms of their active cases.
Exactly. Those countries that saw this first and actually had more cases well before we did in the United States, we've learned a lot because they published and shared what they knew. And that helped inform how we even designed these tests, because they had started making tests even earlier on and seeing what works and what maybe doesn't work. And that's really enabled us to make the best test possible and respond as best we can. There's always going to be room for improvement, but if we can at least do better than, the first round, then that's an achievement, really, and something to celebrate, that we have taken something, learned from it, and started to do things a little bit better.
Thanks, Dr. Rodgers.
Yeah, thanks for those questions. So we've talked a little bit about that early phase of infection and how we could detect the viral RNA to know whether or not someone has an active infection. But now I'd like to move on to talking a little bit more about the antibody tests that we would be able to detect in someone who's starting to recover and is starting to enter that late acute phase or even the convalescence and recovery phase of a COVID-19 illness. And the first markers are going to be IgM. That's the antibody that will appear first. And then we also have IgG coming up a little bit later, although we need to understand better right now as a scientific community what those timelines actually look like. I'd like to point out that this time frame is a general time frame that I'm showing here on this slide. That's kind of our generally true for most viral infections. You'll see the virus first, and then you'll see the immune response. The actual timing, is that a week in between? Is that a month in between? Or is that a day in between? Is something that we're trying to determine scientifically. And I'm going to show some data in a little bit that actually shows what we're looking at right now in terms of when these markers are going to start being present in an infected person. So there's a lot of different reasons that we need antibody tests, and those are listed here. Some of the highlights here, I think, are to be able to tell someone who had a illness earlier and just ultimately wants to know, was that COVID-19 that I had? A lot of people are really curious about that. And an antibody test can give them that peace of mind of knowing, yes, you have recovered from COVID-19, or no, that wasn't actually COVID-19 because you don't have antibodies to COVID-19. So it was something else, and you need to remain vigilant. So this is also going to be important for healthcare providers who are starting to see some unexpected after effects of a COVID-19 illness, to know whether or not the patient that is having some other symptoms now previously has recovered from COVID-19, so that we can start to understand how there might be long-term side effects from recovery from COVID-19. The only way to know that really is with an antibody test, to know who actually has had it in the past. This is also a way that we can identify convalescent plasma donors, because we're starting to see that if people who have recovered have good neutralizing antibodies to COVID-19, that we can actually use their blood and plasma to treat people who are severely ill and don't have those antibodies yet. And there's been studies showing that that's an effective way to treat people and help them recover sooner who are hospitalized. And there's a lot of places where you can actually go out and donate right now if you know you have antibodies to COVID-19. And I'm really encouraged to see that, some friends of mine who have been in this situation found out they had antibodies and have started to donate, that's one way that you can really help people right now, by sharing that donation so that you can help someone recover who doesn't have the antibodies yet. From a public health perspective, the antibody test is also going to be important so that our public health officials can see how broadly the COVID-19 pandemic has actually spread in our communities. And that's going to enable them to make good choices about how we are able to prevent new infections and how we can put in policies that are going to be best for communities depending on how far the virus has actually spread in each of those unique situations. We really need to be looking at regional responses, and the antibody test is going to help us with those responses. So if we actually look at what data we're starting to get about how these markers are becoming detected in different phases of recovery and infection with COVID-19, there's thousands of people who have had this, and a number of them have been included in scientific studies so that we actually have real data now where we're starting to see that someone who's starting to have symptoms will have a detectable level of RNA from the virus in a respiratory sample as early as the first week to 2 weeks of that infection. And so that would be this red line in the plot that I'm showing here. You can see that there's a curve where it's detectable and then it goes down, and then it's not going to be detectable anymore after that first initial period. And this is an average. This isn't true for everybody. There might be some people who still have RNA that's detectable week 4 even. But this is the average, and this is what we're seeing for the majority of cases. And then as we move further on, we start to see that, depending on where you're looking, so we have the respiratory sample, we also have a stool sample where you might have RNA that's detectable much longer, and that is what we're seeing. The big question for us right now as a scientific community is that virus actually infectious? We don't actually know that right now. And for other viruses, we have seen that, you might find virus in urine or stool, but it's not actually infectious. And so studies are ongoing right now to understand whether the virus that we detect in other parts of the body is actually going to present a risk for anyone. So then as we move further on, you'll see that the antibody responses, which are the dashed lines here, are actually coming up almost concurrently. So IgM, usually in a virus infection, we'll see IgM comes up first, and then there's a delay before IgG. What we're seeing in most cases of COVID-19 is actually these are coming up relatively at the same time in most cases, which is, some viruses are like that. Some people respond, and it's interesting to see that, an IgM result would be positive at around the same time as IgG. And so maybe early on that difference doesn't necessarily matter as much. But where it does matter is later on, because IgM will start to go down after someone's been, week 6 out of their recovery phase. That means that if someone is IgG positive and IgM negative, that they're potentially further out from when they had their infection. So that can help us when they're understanding the timing of someone's recovery, which can be important for individual patients, obviously, because you want to know if someone's recovered, months ago versus weeks ago. But it's also important from a public health perspective where we want to know, how long ago was this person recovering from COVID-19? Because that helps us gauge in our communities how long it's been present. So we're now looking at 3 major markers in diagnostic tests to try and understand where someone is in their infection versus recovery. So those 3 markers that we've talked about so far and that are ultimately going to help us make those decisions about how to care for a patient are RNA, IgM, and IgG. So if we kind of think about, how someone would potentially move through all these phases, they'll have a different marker at each phase that's positive or negative. So early on, as we start to interpret, we have a grid here that can help us understand where someone is in each phase of their infection and recovery. First, someone will be positive for just RNA and negative for the immune response, IgG and IgM markers. And that means that they're in their initial early phase of an infection, and they're probably having symptoms. And so you want to make sure that a patient like this is quarantined so that they're not going to spread it to another person, because the presence of that RNA means that they have virus and are actively going to be able to potentially infect someone else. So the next line down has someone who's positive for RNA and IgM, but negative for IgG. So that's where we would classify someone as in that early immune response, although as we've seen, we'll often see someone also being IgG positive potentially at the same time. And so that's a line that's further down, and that seems to be more common than the line where we have IgM positive, IgG negative, and RNA all at the same time. So you might be wondering, how could someone have antibodies and viral RNA at the same time? Because doesn't the antibody basically get rid of the virus? And that might be true. They might actually be complex together. And so that means that the RNA would still be detectable because the virus is still there, but the antibody has bound to it. And so at that phase, we're hoping that that means that the antibody is potentially slowing down the infection, so that it's not, the virus is present, but not able, hopefully, to get into a new cell and make more copies of itself and propagate the infection. But it depends on how much IgM is present, and there's a complex process going on in that phase of infection where your body's trying to really rein in the virus and start to begin the recovery process. So there's another line here that I kind of jumped over, and let's go back to that one, where someone would be RNA negative, IgM positive, and IgG negative. So that's going to be that same kind of phase, but the good news here is that someone's actually gotten rid of their virus because the RNA is gone, and they may not have IgG yet, but they have IgM antibodies, which means that they're recovering from the virus, but they're in that phase that's kind of early on in recovery. Okay, so if we go further down to the line where we have an RNA positive result, IgM negative, and IgG positive, that's a stage of infection where we could potentially have a false positive RNA result because we know that IgG antibodies come out much later. It could also mean that there's some RNA present that is probably not infectious, because if someone's later on in their recovery, they're less likely to have infectious virus. But it's also possible that someone has been reinfected, and that's something that we need to be tracking as we do look at, we haven't had this virus in humans for very long. We've only had people infected with COVID-19 or SARS-CoV-2 for about 6 months. And so that means we're still kind of learning about the reinfection process. So we do want to pay special attention to people who have these kind of unusual results where we're not seeing exactly what we would expect, so that we can understand the reason for that, be it false positive tests or potential reinfections. So then if we continue down the line, we're going to see test results that indicate that someone is further on in the recovery, where they're RNA negative, but then they're positive for one of the serological markers or both of them. And so that phase where we just have the IgG or IgM test results or both coming up positive means that someone's further on in their recovery from COVID-19. And then of course, if someone is negative for all three, that means that they've never been infected because there's no evidence of an infection. Whereas if they're positive for any one of these other markers, that is evidence that they are currently or have in the past been infected. So while we're talking about antibody testing, I want to speak a little bit about herd immunity, which is a term that people have been using a lot because it's an ideal that we want to get to. Herd immunity essentially means that there's enough people in a population who have immunity to a virus so that the people who don't have immunity are protected, because those people are no longer able to spread the virus. And in a lot of cases, a good example would be a vaccine. So we have a vaccine, for example, polio, that will protect babies who are too little to get vaccinated from getting the disease because no one is spreading it who's old enough to get vaccinated. Likewise, someone who has a depressed immune system, like someone on chemotherapy, would also be considered vulnerable, and they would benefit as well from herd immunity. So to establish herd immunity, we need at least about 50% of a population to have that immunity. And one of the ways that we can look at it is with an antibody test. But the important thing to understand first is that we have to know that an antibody is a marker first for long-term immunity, and that immunity will last for hopefully years. So we're still early on. We're not able to say we have herd immunity, even though we have, over 2 million cases in the United States, and that's continuing to grow. In other parts of the world, they've also had a large number of cases. Despite that, the prevalence overall that we're finding so far in our communities is easily less than 5% in most of the places that have done studies to look at just the antibody response that could be detected with an antibody test. And even that doesn't tell us whether or not all of those people are really actually protected from getting reinfected. Because for herd immunity to work, the people who have the immunity have to be protected from reinfection so that they can't continue to spread the virus. And so although this is potentially in the future, we're not there yet. And the good news is that we're able to start doing those studies to be able to understand whether or not immunity is first protective, and second of all, how we can determine who has it so that we can try and get to that herd immunity if a vaccine becomes available. So as we all know, there's a lot of questions. I have a lot of questions, you have a lot of questions. We don't have answers to all of them yet, but the important thing is that we have all of this collaborative network of scientists out there who are trying to get answers, are working passionately hard to get answers to these questions by doing the research studies that are needed. But some of the questions that come to my mind are that we still don't really know where SARS-CoV-2 came from in an animal reservoir. And so, it's mostly important to answer that question so that we can prevent this from potentially happening again. Because if there's still animals out there that have this virus, but maybe a slightly different strain, there's always going to be potential for that to jump into people again, the way we saw it happen in late December 2019. And so we really want to be able to identify that reservoir, and people are currently working right now to try and understand what animals this may have come from. The next question is whether the antibody responses are actually protective. We're starting to see some studies where people who we know have antibodies are donating their plasma, and then we take that plasma and see if we put it on a cell culture, if it can actually block the virus from getting into cells, because that would mean that the virus is actually going to protect the cells and theoretically also protect people who have those antibodies. And some people do. The actual percentage is something we're trying to understand, but I think it's also important to know that antibodies aren't the only way that someone can be protected from COVID-19 infection. You also have a whole cell-mediated immune response that could work just fine, even if antibodies aren't actually blocking the virus from getting into a cell. And so this is a really complex question. It starts out as simple, thinking, well, are antibodies protecting us? But even if they're not, we also need to take a step further to try and understand how all the other aspects of our immune response could potentially be protecting people who have recovered. So that's an active area of investigation right now. Related to that is whether or not people can be reinfected after recovery. This might have happened occasionally here and there, but as I mentioned earlier, that could also be indicative of potential false positive or false negative test results. And so teasing those details apart are going to help us understand, especially in a large scale study where we're looking at a lot of people who have recovered, to see whether or not they're actually reinfected will ultimately help us to answer this question. The million-dollar question right now is whether or not antiviral treatments could be effective and whether we could get a vaccine that will protect people. Those are also very active areas of investigation. I think the last number I saw was there's over 60 different strategies currently being explored for vaccines specifically, and I know there's a number of studies going on for antiviral treatments right now. And that gives me a lot of hope that with all of these different potential solutions, that hopefully one of these will come to fruition and be demonstrated to actually protect people or treat people who are sick. And so that gives me a lot of hope, and I hope it gives you a lot of hope too, because that's what we need right now. We need something that will actually help people who are sick or prevent new infections. And I think that's where I'll hand it over to Dr. Blouin about, some of our final thoughts about what nurses need to know And maybe you could speak to some of these more specific things that will help our nurses out there.
Thank you so much, Dr. Rodgers. We really appreciate your giving us a terrific overview both of RNA detection for the virus and also antibody testing. And so in summary, I'd like to just talk about some final thoughts. Testing to detect the virus or its antibodies really has great value. There's been some discussion in some corners of our country that testing is not that important. And as you can see and hear from today's discussion, there is great value in understanding who has indeed COVID-19 and who has developed antibodies from having the disease. Proper specimen collection is key. If the specimen's not collected properly, especially with the nasopharyngeal swab, as Dr. Rodgers discussed, we may get a false negative test. Asymptomatic carriers we know can shed the virus. We don't know how many people there are that are asymptomatic but actively shed the virus, but how and where that spread occurs is rather unclear. We do know that a lot of density in indoor spaces with a lot of respiratory transmission, shouting, yelling, singing, unfortunately, as reported in the Wall Street Journal, those are ways that the virus can be spread. The routes for spread we know can be oral, nasal, ophthalmic, and actually there's some new research that shows in children that there is active virus present in the ears. As Dr. Rodgers really effectively outlined for us, both false negatives and false positives may occur, which leads us as nurses to think about the fact that if we get a test, it may or may not be both sensitive and specific. And in those cases, it may not hit the threshold and not actually be representing the state of the patient. Antibodies could prevent reinfection. We just don't know, and we don't know the immunity length of time. Is it a short length of time? Is it a longer length of time? These are things that are currently being studied. We do know that patients who have the antibodies, as Dr. Rodgers indicated, can contribute convalescent serum, and that's something we can do to help other people if we have had COVID-19 and have antibodies. And then right now, every day, there are multiple studies, multiple comments that are coming out in the press, on the internet, about the presence or potential for vaccines and for effective drugs for treatment. Frankly, the jury is still out on a lot of that data, and we wait to and hope, as Dr. Rodgers indicated, that there'll be positive news soon, both on the treatment side for patients that have that in addition to the convalescent serum, and then also on the vaccine side, because that really will enable us to reach the herd immunity that Dr. Rodgers just discussed. We thank you for listening in to this webinar, and we hope that you will listen in to webinars 2 and 3. Webinar 2 will cover ambulatory and communities of care in high-risk populations within a primary care network, and webinar 3 will cover, we'll talk about protecting yourself as a nurse, your family, and your patients as we slowly reopen our country. Thank you very much.